So ethmoid is the brain in the base of brain, right? It has a cribriform plate or a sieve-like structure through which the olfactory nerve, it pierces through the ethmoid plate and goes into here, the olfactory bulb, and you have again the same neuron, they have another axon, okay. So this is the first order neuron, this is the first order neuron, and the second order neuron is the olfactory tract. This is the second order neuron, and third order neuron, there are two different types of third order neuron, two different routes actually. One goes to contralateral olfactory bulb and another goes to primary olfactory cortex, okay, goes to primary olfactory cortex. Now these are the first order neuron, the olfactory receptor neuron, they are located in the olfactory epithelium, okay. These neurons are located in the olfactory epithelium and they detect the molecules dissolved in the mucus, okay, the molecules dissolved in the mucus. Each receptor express only one type of olfactory receptor proteins, right, and they pierce the cribriform plate of ethmoid and moves into the base of the brain, right. Now the olfactory nerve, it is formed by the same neuron, same neurons unmyelinated axons forms the olfactory nerve, right, and these fibers converged and terminate into the olfactory bulb. And olfactory bulb is basically nothing but the second order neuron nucleus, okay, the nucleus of the second order neuron or the cell body of the second order nucleus, second order neurons, and these cells are called the mitral cells and the tuft cells, right. Now next, the olfactory tract, I told olfactory tract, from olfactory tract you have two different pathway. I'm again showing the picture, okay. So here is the olfactory tract, and olfactory tract goes into opposite side, that is contralateral bulb, and also goes into the olfactory cortex, right, olfactory cortex. So two different pathway, one is lateral olfactory stria, another is medial olfactory stria. Lateral goes to the primary olfactory cortex and the medial goes to the contralateral bulb, okay. Now primary olfactory cortex, you need to remember primary olfactory cortex, that essentially means the piriform cortex, periamygdaloid cortex and part of entorhinal cortex. These are all the part of temporal lobe. You will study in anatomy, specific location, right. Now there are some secondary projections. Secondary projections will be there into orbitofrontal cortex for consciousness, and for to amygdala for emotional response, and also for hippocampus. If you remember hippocampus, we had talked lots of things on hippocampus, that is the gateway of memory. So once you smell something, you remember that in future if you have a similar smell, you can recognize. So that is why you need to build a memory of that smell. So that is why fibers also goes to hippocampus, smell related, it causes smell related memory, and it also goes to hypothalamus for autonomic and endocrine response, okay. Your specific response of a smell, maybe a good smell or bad smell, your specific response, that depends on endocrine and autonomic response, right. So the fibers must go into hypothalamus as well, okay. That's it, nothing more from olfaction. So you need to remember the olfactory pathway, okay. Now next is taste or gustatory pathway, taste neural pathway, taste neural pathway. So may I ask you, anterior supply of anterior 2/3 of the tongue and posterior 1/3 of the tongue. Anterior 2/3 of the tongue is supplied by, yes, chorda tympani, which is a branch of facial nerve. Very nice. So anterior 2/3 of the tongue, taste sensation is carried by facial nerve, and the specific branch is chorda tympani nerve. জীবনে কোনোদিন ভুলবে না, very important, right? Okay. And the posterior 1/3 of the tongue is taste sensation supplied by glossopharyngeal nerve. Very nice. Glossopharyngeal nerve. Posterior 1/3 of the tongue is supplied by 9th cranial nerve or the glossopharyngeal nerve. And palate থেকেও কিছুটা taste sensation আসে, that is carried by cranial nerve 10, right? Okay. So moving on. So receptors are, or the taste bud, there are 5 different types of taste buds, okay. So these taste buds are located mainly on the tongue, found on the soft palate, pharynx and epiglottis as well, okay. Okay, so anterior 2/3 of the tongue carried by facial nerve, sweet, salty, umami taste and sour, right. So 4 different types of taste sensation is carried by cauda tympani nerve, which is a branch of facial nerve, from anterior 2/3 of the tongue. From posterior 1/3 of the tongue, the cranial nerve responsible is glossopharyngeal nerve. It is for bitter taste. Okay, this table you need to remember. Okay, anterior 2/3 of the tongue, facial nerve, specifically cauda tympani nerve, which is a branch of facial nerve, and the taste sensation are everything other than bitter. Okay, and the posterior 1/3 of the tongue is glossopharyngeal nerve or cranial nerve 9. It is for bitter taste sensation, right? Epiglottis and pharynx for minor taste input, and this is carried by cranial nerve 10. Okay. Okay. So now coming back to the picture. So you see all these 3 cranial nerves, they converge into one specific part which is called nucleus tractus solitarius. Nucleus tractus solitarius in the brainstem. Okay, where have you studied nucleus tractus solitarius elsewhere? আর কোথায় nucleus tractus solitarius পড়েছো কোন pathway তে? Very important in cardiovascular system. Yes, in baroreceptor reflex. In baroreceptor reflex. Okay. So anyway, glossopharyngeal nerve, cauda tympani nerve, and the lingual tonsillar nerve, which is a branch of 10th. So they converge into nucleus tractus solitarius in the brainstem. From nucleus tractus solitarius, straight it goes to thalamus. Okay, and from thalamus to cortex. Very simple pathway. Very simple pathway. So here is your 3 nerves. From anterior 2/3 of the tongue, posterior 1/3 of the tongue, and from soft palate, all these 3 nerves converge into the nucleus tractus solitarius in the brainstem. From nucleus tractus solitarius goes straight to thalamus. There is a specific nucleus of thalamus as well. Okay, and finally it goes to the orbitofrontal cortex and insular cortex, right? Which is a gustatory cortex for your taste sensation, right? Okay, so let's read it out. So fast order neurons are the cells of fast order neurons are basically the neurons of these 3 cranial nerves, and they are specific ganglions or their cell bodies are located in the geniculate ganglion for cranial nerve 7, petrosal ganglion for cranial nerve 9, and nodose ganglion for cranial nerve 10. All these are in anatomy part, you will study. Okay, the detailed pathway of the cranial nerves, right? I am not going into details into it. And the fibers goes to nucleus tractus solitarius rostral part in the medulla oblongata, right? Okay, now the 3rd order neuron moves from nucleus tractus solitarius to the thalamus. Which part of the thalamus? VPM, ventral posteromedial nucleus of the thalamus. Okay, and now finally from thalamus to cortex. Which part of the cortex? Anterior insula and frontal operculum, right? So this is everything about taste sensation. Very simple pathway. You need to remember auditory or visual থেকে আমাদের অনেক কিছু পড়তে হয়. It's a big thing, right? But for smell pathway and taste pathway, just remember the pathway. That's enough. Okay, just remember the path. That's enough. Okay. Okay, so smell আর taste খুব rapid শেষ করে দিলাম because এর মধ্যে বেশি কিছু নাই. Just remember the pathway. Pathway is important. Okay, you need to be able to draw the pathway. Okay, simple thing that is asked in the examination. Okay, smell pathway and taste pathway, right? Okay. Okay, now today's core topic, I am moving into the today's core topic, which I was supposed to take, that is physiological changes in pregnancy. Okay, completely different topic. I am moving from special sense to physiological changes in pregnancy. Okay, completely different topic. Okay, so let's begin. Physiological changes in pregnancy. Okay, so physiological changes in pregnancy might be a big topic for you or might be a short note as well, or there might be few specific explain why type of question. So physiological changes in pregnancy is really important. Okay, and definitely you will study much more details of physiological changes in pregnancy in your final year during studying gynecology and obstetrics, right? Okay, but still here also physiological changes in pregnancy is important. Okay, and I'll give you as much detail as possible, right? Okay, because it is important, right? Okay, so physiological changes in pregnancy we will discuss system wise. What are the changes in cardiovascular system? What are the changes in respiratory system? Changes in endocrine system, changes in nervous system, right? So pregnancy, it's not a disease, right? It's not a disease, right? It is a normal physiological thing, and there are some changes. Okay, there are lots of changes, tremendous changes in the body, right? That the mother has to bear with, right? So, what are the changes? Physiological changes in pregnancy? Yes, there might be some abnormality as well when these physiological changes aggravates. Okay, there might be some abnormality, there might be some pathology, right? That we might need to treat, but to some extent it is normal. Okay, to some extent it is normal. Okay, so first change is cardiovascular system. What cardiovascular system uh, adoption are likely to happen in pregnancy? Any idea? Any idea what should happen? What should happen to the heart rate? What should happen to the stroke volume? What should happen to the blood volume? What should happen to the peripheral resistance? Okay, any idea? Any idea? And why it should happen? See, basically, pregnancy is a state of uh, hormonal, not imbalance, but change, a huge change in the hormonal balance, right? Huge change in the hormonal balance, and mostly in almost all cases, these hormonal changes are responsible for all the changes happening throughout the body. Whatever is happening to kidney, whatever is happening to heart, whatever is happening to your hematological system or liver, right? So what should happen in cardiovascular system? Okay, so let's see what is happening in cardiovascular system. In cardiovascular system, first and most important thing is increase in cardiac output. Okay, increase in cardiac output. So increase in cardiac output by 30 to 50% due to both, cardiac output is stroke volume into heart rate, right? Cardiac output is stroke volume into heart rate. So both stroke volume and heart rate will increase, and ultimately as a multiplication, as cardiac output is the multiplication of stroke volume and heart rate, cardiac output is significantly increased, right? Cardiac output is significantly increased, where heart rate increases by 10 to 15 beats per minute. Okay, heart rate increases by 10 to 15 beats per minute. Okay, so definitely you have a demand, right, to increase cardiac output, because we need to supply essential nutrition, oxygen, everything to fetal circulation, right? So cardiac output must increase, right? So this is a very essential thing. Okay, so this is normal, up to 30 to 35% increase in the cardiac output. This is absolutely normal, but abnormality happens when the mother's cardiovascular system is already compromised and the heart is not capable of dealing with this extra cardiac output. Getting my point? When the heart is already compromised, okay, when the heart is already compromised, ejection fraction is low, or the mother is having heart failure previously, so this extra cardiac output is then maybe deleterious or harmful, right? Then you need to treat the patient, right? Otherwise, 30 to 50% increase in the cardiac output is absolutely okay and within physiological limit, right? Okay, now blood pressure decrease in first and second trimester. Okay, blood pressure decrease in first and second trimester, which returns to normal, which should return to normal, which is supposed to return to normal by the end of third trimester. Okay, so what is the cause of this reduction in blood pressure in first and second trimester? Corpus luteum. Corpus luteum secretes what? Progesterone, right? Corpus luteum of pregnancy, it secretes progesterone. Okay, and this progesterone has got a vasodilatory effect. Okay, this progesterone has got a vasodilatory effect. So as a result of this, peripheral resistance will decrease. Okay, so systemic vascular resistance, peripheral resistance will decrease, and finally blood pressure will fall. Okay, blood pressure will fall during first and second trimester of pregnancy, right? And finally, heart sound you may hear due to increase in cardiac output, because increase in cardiac output, stroke volume is high. Okay, so every stroke, heart is pumping extra blood in circulation, right? With every beat, heart is pumping extra blood in circulation. This extra amount of volume that is moving through the aortic aperture, it will cause a systolic murmur. Okay, so if you put a stetho over here, normally we hear systolic murmur in case of severe anemia, in case of aortic stenosis, so valvular heart defect. So systolic murmur in this case, case of pregnancy, it is absolutely normal. So you may hear a systolic murmur if you put stethoscope over the mother's chest wall, aortic area, you will listen a systolic murmur, and that is absolutely normal. There is nothing to do with valvular heart disease, or it is not valvular heart disease, or it is not due to severe anemia. So pregnancy physiologically leads to a systolic murmur. Okay, now venous pressure increases due to this huge volume load. Venous pressure increases and risk of varicose vein and edema is there. There is risk of varicose vein, edema, and there is chances of supine hypotension. Whenever the patient, not the patient, mother, whenever mother lies down, what happens? The gravid uterus falls on the IVC, inferior vena cava. It compresses the vena cava, right? And as a result, due to compression of this inferior vena cava, there is supine hypotension. Whenever patient lies down, or mother lies down, a pregnant mother is not a patient, right? Okay, so whenever the mother lies down, there is hypotension, right? Hematological system, very important, and I say most important. Okay, the changes in hematological parameters, in pregnancy. What should happen? What do you think? What should happen? What should happen to patients, or the pregnant mother's blood? What should happen? What should happen to WBC? What should happen to RBC? Or what should happen to hemoglobin, hematocrit, whatever? Any idea? What should happen? What is the ultimate goal? You need to supply nutrition, oxygen to the fetus, right? So what should happen? What should happen to RBC count? No idea. Okay. So first of all, plasma volume increased by 50%, red cell mass increased by 25%. Okay. So red cell mass, RBC count is definitely increasing, but the thing is, volume is increasing by 50%. So as a result, there is dilution. Okay. So plasma volume increases by 50%, whereas red cell volume increasing by 25%. So it is a dilutional state, right? It is a dilutional state, and there is physiological anemia. There will be anemia, physiological. So if you calculate red cell count, it will be low, but ultimately total body RBC count is increasing. Total RBC count is increasing. Okay. So as a result, hematocrit will fall, hemoglobin will fall, because volume is increasing. Red cell is also increasing, but not in accordance with the volume, right? So as a result, there is low hemoglobin, low hematocrit, right? Okay, and finally, WBC count, specifically neutrophil, is increasing. We know that neutrophil increases during infections, right? Acute pyogenic bacterial infection. Neutrophils increases during acute pyogenic bacterial infection. But here in pregnancy, normally physiologically neutrophil is increasing, and it is the effect of estrogen that is stimulating specific lineage in the bone marrow, right? It is the effect of estrogen stimulating specific lineage of the bone marrow, which increases the production of neutrophil, and also cell-mediated immunity. There is conversion of cell-mediated immunity to humoral immunity, Th1 response to Th2 response, right? Now, pregnancy is a hypercoagulable state. Okay, pregnancy is a hypercoagulable state. Okay, there is increased tendency to clot formation. Okay, why it is required? Okay, everything has a purpose. So what I mean is, everything has a purpose. If blood volume increases, it has a purpose. If RBC count increases, it has a purpose. If cardiac output increases, it has a purpose. So pregnancy is a hypercoagulable state. That means easily blood clot kore jabe. Okay, easily blood clot kore jabe. Keno? Because clotting factor kothay manufacture hoy? Clotting factor factory kothay? Blood clotting factor factory ta kothay? Liver. Yes, very nice. Liver. Okay. So estrogen stimulates hepatocytes to produce more clotting factors. Okay, which clotting factors? 7, 8, 9, 10 and fibrinogen. Okay, it decreases protein S. So there is increased risk of clot formation. Okay, increased risk of clot formation. Very frequently it happens. Okay, up to some extent it is normal, but when it is extremely hypercoagulable, the pregnant mother may develop deep vein thrombosis. Okay, deep vein thrombosis and other thrombotic phenomenon as well. So sometimes it is risky. Okay, sometimes it is risky, but yes, this hypercoagulable state is also required. Why? Because the nature prepares the mother for delivery. Okay, during delivery there is chances of extreme blood loss. Okay, so to prevent that blood loss, it is the nature's mechanism to make the blood hypercoagulable, so that bleeding is less during delivery. Okay, so that bleeding is less during delivery, and it is whole phenomenon is mediated by estrogen, which stimulates hepatocyte to synthesize more and more clotting factors. Okay, so there is also chances of risk of thromboembolism when this physiological phenomenon it is aggravated and beyond a physiological limit. There is chances of thrombosis. There is chance of thrombus formation in the circulation, like deep vein thrombosis, right? Very nice. ESR is erythrocyte sedimentation rate. What does it signify? কোনো পেশেন্টের ESR বেশি হলে আমরা কি ভাবি? Yes, কোনো পেশেন্টের ESR বেশি, তার মানে আমরা কি ভাববো? এরিথ্রোসাইট সেডিমেন্টেশন রেট মানে কি? একটা টিউবের মধ্যে আমরা দুই রকম টিউব ইউজ করি, একটা ওয়েস্ট্রোপস টিউব, একটা ওয়েস্টার্ন টিউব, তাই তো? এই দুটো টিউবের মধ্যে আমরা ব্লাড রেখে দিই। ওকে, ব্লাডটাকে অনেকক্ষণ ধরে রেখে দিই। 1 ঘন্টা পরে দেখি যে কতটা আরবিসি সেটেল ডাউন হয়ে গেল, তাই তো? কতটা সেটেল ডাউন হয়ে গেল সেটাকে আমরা মেজার করি। ওকে, সেটা 18 mm 20 mm এরকম মোটামুটি নর্মাল হয়, ঠিক আছে? এবার কখনো যদি দেখি ESR অনেক বেশি 100 90 80, তাহলে আমরা কি ভাববো? কি আছে? অ্যানিমিয়া আছে। আচ্ছা, আর কি আছে? আর কি হতে পারে? কেন ESR বাড়তে পারে? Tuberculosis. Very nice. Tuberculosis. So basically it is a marker of infection and inflammation. Okay, যখন ESR বেশি থাকে তখন আমরা ভাবি পেশেন্টের নিশ্চয়ই কোনো ইনফেকশন বা ইনফ্লামেশন রয়েছে। An inflammatory process is going on. Tuberculosis is an example of chronic inflammatory disease, chronic inflammatory procedure, right? So যে কোনো টিবি পেশেন্টের আমরা ESR করব, দেখবো 70 80 90 মানে অনেক বেড়ে আছে, ঠিক আছে? কেন? বিকজ tuberculosis is a state of inflammation. Okay, state of inflammation. এবার ইনফ্লামেশনে তো ESR বাড়ে, but why there is high ESR in pregnancy? Okay, why there is high ESR is in pregnancy? Because pregnancy is not an infection, right? Pregnancy is a normal physiological thing, it is not an infection, right? So let's see what does it say. Okay, so ESR টা বেসিক্যালি হয় কেন? মানে এরিথ্রোসাইট হোয়াই আমরা ব্লাড যখন রেখে দিই তখন আরবিসি গুলো সেটেল ডাউন করে যায় কেন? এনি আইডিয়া? কেউ বলতে পারবে কেন হয়? কেন আরবিসি গুলো সেটেল ডাউন করে যায়? নরমালি আমাদের সার্কুলেশনের মধ্যে তো সেটেল ডাউন করছে না। আমাদের সার্কুলেশনে যখন ব্লাড ফ্লো করছে তখন আরবিসি কি সেটেল ডাউন করে যাচ্ছে? করছে না, রাইট? সো দ্য অ্যান্সার অফ দিস ইজ রুলু ফর্মেশন। The pronunciation is not rulex, it is rulu formation, right? Okay, so these are stacks of RBC. ক্যারাম খেলেছো কেউ? ক্যারামের গুটিগুলো একটার পর একটা যে স্ট্যাক করে রাখা হয়, সেরকম আরবিসি গুলো এরকম স্ট্যাক হয়ে যায়, একটার পর একটা স্ট্যাক হয়ে যায়, রাইট? যখন আমরা ব্লাডকে রেখে দিই তখন আরবিসি গুলো একটার পর একটা স্ট্যাক হয়ে যায়, সেটাকে আমরা বলি রুলু ফর্মেশন অর স্ট্যাক ফর্মেশন, রাইট? So these are stacks of RBCs that resemble pile of coins. Okay, that resemble pile of coins. They form when plasma proteins, specifically fibrinogen and globulins, neutralize the normal repulsion between the RBCs. Okay, and this causes RBCs to stick together, increasing their weight and making them sediment faster. তাহলে এখানে কি বললো? যে আরবিসি, একটা আরবিসি আরেকটা আরবিসি কে রিপালশন করে নরমালি। ওকে, so due to their specific charge on the cell membrane, একটা আরবিসি আরেকটা আরবিসি কে নরমালি রিপালশন করে। But what happens when protein is increased? Okay, proteins like specifically fibrinogen, the most important protein here is fibrinogen, right? Fibrinogen and globulins. So when these type of proteins, fibrinogen, globulin, these types of protein increases in blood, so they just destroys the repulsion between two RBCs, because protein has its own charge. So there is a big mechanism So we are not going into the detailed electrophysiological mechanism, what is happening, how this charge is influencing another charge. Okay, we are not going into details. Just remember that two RBCs, they repulse each other. একটা RBC আরেকটা RBC কে বিকর্ষণ করে, right? Okay. Now, when there is increased protein in blood, these proteins, particularly fibrinogen, globulin, and acute phase reactants. Okay, acute phase reactants. মানে কোনো ইনফেকশন হলে যে প্রোটিনগুলো বাড়ে আর ঠিক আছে, যেমন সি রিঅ্যাক্টিভ প্রোটিন, তারপরে সেরাম ফেরিটিন ইজ অলসো অ্যান অ্যাকিউট ফেজ রিঅ্যাক্ট্যান্ট। তো যাই হোক, এই প্রোটিনগুলো যখন ব্লাডে বাড়ে, দে জাস্ট ডিস্ট্রয় দি রিপালশন বিটুইন টু আরবিসিস। সো অ্যাজ এ রেজাল্ট দ্য আরবিসিস comes together and forms RULU. Okay, right? So they form when the plasma proteins neutralize the normal repulsion of RBCs. RBCs এর normal repulsion টা যখন destroy হয়ে যায়, right? Okay, so RULU formation এর তিনটে mechanism আছে. The role of reduced RBC count or anemia in RULU formation. ঠিক আছে, তাহলে তো আমরা বুঝতে পারলাম যে ব্লাডে যদি কোনো কারণে প্রোটিন বাড়ে, মানে ফিব্রিনোজেন বাড়ে বা অ্যাকিউট ফেজ রিঅ্যাক্ট্যান্টস বাড়ে, তাহলে রুলু ফর্মেশনটা ফাস্ট হবে এবং আমাদের ইএসআর বেড়ে যাবে। তার মানে যে কোনো ইনফেকশনে, ওকে, যে কোনো ইনফেকশনে অথবা যেখানে গামা গ্লোবিউলিন বেড়ে যাচ্ছে, যেমন মাল্টিপল মাইলোমা, যেখানে গামা গ্লোবিউলিন অনেক বেড়ে যাচ্ছে, সেখানে আরবিসি গুলো স্ট্যাক করে রুলু ফর্মেশন করছে, রাইট? বাট হোয়াট ইজ হ্যাপেনিং ইন অ্যানিমিয়া? অ্যানিমিয়াতে তো কোনো ইনফেকশন হচ্ছে না, কোনো প্রোটিনও বাড়ছে না, রাইট? তাহলে সেখানে কেন ইএসআর বেড়ে যাচ্ছে? The thing is, it is actually the number of RBC and protein ratio. Okay, number of RBC and protein ratio. যদি number of RBC কমে যায়, মানে অ্যানিমিয়া হয়, if there is reduction in the number of RBCs, there will be relative increase in protein content. Getting my point? যদি RBC কমে যায়, তাহলে RBC রেসপেক্টে প্রোটিন বেশি, right? So this is why it is easier to form the RULU formation in anemia, right? So let's see what is happening. In anemia, there are fewer RBCs in the same volume of plasma. This increases the relative concentration of plasma protein like fibrinogen, globulin per RBC. Per RBC जो protein है, that is being increased, right? And higher protein to RBC ratio facilitates RULU formation since more protein is available to coat and link the cells. Clear? Very important question. Very important question, right? It may come as an MCQ in your NEET PG. It might be asked in the Viva examination, and it may be placed as an explain why question as well. Very important. You must not forget. Okay. Okay. Now there are some exceptions as well. Anemias with high ESR. ঠিক আছে, যে যে অ্যানিমিয়া, অনেক রকম অ্যানিমিয়া আছে, তো অ্যানিমিয়াস উইথ হাই ইএসআর, কোন কোন অ্যানিমিয়াতে ইএসআর বাড়ে? ইয়েস, ম্যাক্সিমাম অ্যানিমিয়াতে ইএসআর বাড়ে, বিকজ দ্য রুল সেজ সো। ঠিক আছে, যে নিয়মটা সেটা তাই বলছে যে অ্যানিমিয়াতে ইএসআর বেড়ে যাওয়া উচিত, কারণ আরবিসি কন্টেন্ট যদি কমে যায়, then there will be relative increase in the percentage of proteins. Okay, and proteins are responsible for neutralizing RBC repulsion. Okay, proteins are responsible for RBC repulsion, and this RBC repulsion is just destroyed with increased amount of protein, right? যেটা হয় টিউবারকুলোসিসে, যেটা হয় যে কোনো অ্যাকিউট পায়োজেনিক ইনফেকশনে, যেখানে সিআরপি বেড়ে যাচ্ছে, ফেরিটিন বেড়ে যাচ্ছে, এগুলোও প্রোটিন, এগুলোও ফিব্রিনোজেনের মতো কাজ করছে, রাইট? ওকে, ফিব্রিনোজেন, সিআরপি, এগুলো সব হচ্ছে অ্যাকিউট ফেজ রিঅ্যাক্ট্যান্টস। যখনই ব্লাডে কোনো প্রোটিন বাড়বে, পার্টিকুলারলি এইগুলো, তখন relative percentage of protein will increase and they will destroy RBC repulsion. As a result, ESR will be high. So that should happen in anemia as well, because relative percentage of RBCs are decreasing. So what type of anemia? Anemia of chronic disease like CKD, chronic kidney disease, macrocytic anemia, hemolytic anemia, and iron deficiency anemia. All these things will be characterized by high ESR. এগুলো সবইতে আমার high ESR হবে, okay, except one, anemias with decreased ESR. Okay, again very important MCQ zone, right? So in sickle cell anemia and hereditary spherocytosis, these are two exceptions. Sickle cell anemia and hereditary spherocytosis, ESR may be actually normal or decreased because of abnormal RBC shape, which prevents rulu formation. Okay, because of abnormal shape, they prevents rulu formation and increased rigidity of RBCs. Okay, so does reduced cell count directly increase rulu formation? No, not directly, but reduced red cell count contributes to a higher ESR. It facilitates rulu formation indirectly by changing the balance between plasma protein and RBC concentration. Already talked. What is rulu formation? Absolutely talked. Okay, another reason is fewer RBC means less viscosity. It also facilitates rulu formation. Okay, তাহলে অ্যানিমিয়া প্লাস ইনফ্লামেশন। ওকে, যেমন টিউবারকুলোসিস অ্যানিমিয়াও হয়, আবার যেহেতু ইট ইজ এ স্টেট অফ ইনফ্লামেশন, ওকে, ইট ইজ এ স্টেট অফ ক্রনিক ইনফ্লামেশন, টিউবারকুলোসিস ইজ এ স্টেট অফ ক্রনিক ইনফ্লামেশন। So like TB, autoimmune disease or chronic infection, there is markedly high ESR. This is because two reasons. One is anemia and another is inflammation, right? So এখানে ESR মানে excessively high হবে. It may even cross 100 in first hour, 100 mm. Okay. তাহলে তার আগে আরেকটা জিনিস বলে দিই, তাহলে প্রেগন্যান্সিতে আমার ইনফ্লামেশন এগুলো হতেই পারে, ঠিক আছে? তাহলে প্রেগন্যান্সিতে আমি কোনো প্রেগনেন্ট মাদারের যদি দেখি যে ESR হাই, তাহলে আমি এই ডিসিশনে আসবো না যে পেশেন্টের কোনো ইনফেকশন আছে বা ইনফ্লামেশন আছে। ওকে, সো ইউ নিড টু ক্রস চেক উইথ এ ডিফারেন্ট মার্কার অফ ইনফ্লামেশন লাইক সি রিঅ্যাক্টিভ প্রোটিন। সো সি রিঅ্যাক্টিভ প্রোটিন ইজ দ্য বেস্ট মার্কার অফ, মানে এটাও এমসিকিউ ফর্ম হতে পারে যে হুইচ ইজ দ্য বেস্ট মার্কার অফ ইনফ্লামেশন ইন প্রেগন্যান্সি। তো সেখানে ESR অপশন থাকবে, সিআরপিও অপশন থাকবে, আনসার হবে সিআরপি, ঠিক আছে? তাহলে প্রেগন্যান্সিতে আমাকে যদি ইনফেকশন রুল আউট করতে হয়, ইনফ্লামেশন রুল আউট করতে হয়, তাহলে ESR টেস্ট করলে হবে না, আমাকে কি টেস্ট করতে হবে? সিআরপি, সি রিঅ্যাক্টিভ প্রোটিন। So isolated elevated ESR is not a reliable marker of inflammation in pregnancy, right? It should not be used alone to diagnose infection or inflammatory condition in a pregnant woman. CRP is preferred if inflammation assessment is required, right? Very important. Okay, ESR values in pregnancy you may remember. Okay, so first trimester normal is below 18, so first trimester 18 to 48, second trimester 30 to 70, and third trimester 40 to 100. Okay. Okay, what happened to respiratory system? What happened to respiratory system of the pregnant mother? Okay, tidal volume ফার্স্ট। কি কি প্যারামিটার চেঞ্জ হতে পারে, মানে প্যারামিটারগুলো ভাববে এটা কি চেঞ্জ হতে পারে, ঠিক আছে? আমি যখন কার্ডিওভাস্কুলার সিস্টেম ভাববো তখন আমি ভাববো কার্ডিয়াক আউটপুট কি চেঞ্জ হতে পারে, হার্ট রেট কি চেঞ্জ হতে পারে, স্ট্রোক ভলিউম কি চেঞ্জ হতে পারে, ওকে, পেরিফেরাল রেজিস্ট্যান্সের কি চেঞ্জ হতে পারে। সেরকম আমি রেসপিরেটরি সিস্টেম যখন ভাববো তখন আমি প্যারামিটারগুলো ভাববো, রেসপিরেটরি সিস্টেমের কি প্যারামিটার আছে যেগুলো আমরা মেজার করি, টাইডাল ভলিউম মেজার করি, মিনিট ভলিউম মেজার করি, তো এগুলো কি চেঞ্জ হতে পারে? ইয়েস, বাড়বে, ডেফিনেটলি বাড়বে, রাইট? ওকে, সো লেটস সি হোয়াট হ্যাপেন্স। So tidal volume increased by 30 to 40%. Respiratory rate, no change in respiratory rate. Remember, there is no change in respiratory rate, only tidal volume will increase, and as a result of increase in tidal volume, minute volume will also increase. Okay, PaCO2, there will be mild respiratory alkalosis. Okay, there will be mild respiratory alkalosis. Ektu respiratory alkalosis thake. Pregnant mother একটু respiratory alkalosis থাকে due to decrease in partial pressure of carbon dioxide in arterial blood, and this is due to facilitate CO2 diffusion to the fetus. There will be increased oxygen consumption, and dyspnea is usually common due to increased respiratory drive and pressure on the diaphragm. Okay, as the gravid uterus increases in size, it causes pressure on the diaphragm, and as a result there is mild respiratory distress or dyspnea. Okay, and it is common, it is up to a certain limit, it is physiological, right? So it is common due to increased respiratory drive and also pressure on the diaphragm. Renal, what happened to kidney? The most important parameter we see in kidney is kidney কোন প্যারামিটারটা আমরা সবচেয়ে বেশি দেখি পেশেন্টের? GFR। বল, GFR কি হবে, কি করতে হবে, বাড়াতে হবে না কমাতে হবে? ডেফিনেটলি বাড়াতে হবে। So renal blood flow increases by 50%, GFR also increases by up to 50%, and as a result of increased GFR, serum urea creatinine will fall. Mild glycosuria may happen, মানে ইউরিনে একটু সুগার আসতে পারে, নরমালি ইউরিনে সুগার আসে না, but in pregnancy up to a certain limit glycosuria is normal. Okay, and as a result of this glycosuria there is increased chance of UTI. Okay, urinary sugar elei there will be increased chances of urinary tract infection. Okay, so a pregnant mother is prone to develop urinary tract infection. Okay, that we must take care of. GI system, gastrointestinal system. Okay, slowed gastric emptying and motility due to progesterone. It is due to progesterone effects. So some effects are due to estrogen and some effects are due to progesterone. Reduction in gastrointestinal motility is due to progesterone effect, right? Lower esophageal sphincter tone, as a result patient will be having, or the pregnant mother will be having reflux. Okay, very frequent reflux, and in aggravated cases, in excessive reflux, we can treat the patient. Okay, we need to treat the patient. So patient will be complaining of GERD, heartburn, right? Reflux, acid coming out, right? And heartburn, right? Constipations common. Hemorrhoids may occur due to increased venous pressure. Hemorrhoids may occur, and in liver function test, you will see alkaline phosphatase is high, but this alkaline phosphatase, it is not coming from liver. The source of alkaline phosphatase is from placenta, right? So if we perform liver function test in a pregnant mother, we see high level of alkaline phosphatase. So it is nothing to worry, because this source of alkaline phosphatase is not liver in this case. The source is placenta, right? Okay, there is increased chance of gallbladder stone formation due to biliary stasis. Endocrine system. What happens to endocrine system? This is very important. Endocrine system. Okay. The effect of estrogen is to increase, I told that estrogen increases protein synthesis from liver. That protein might be in the form of clotting factors, or that protein may be in the form of binding globulins. Okay, the T3, T4 hormones, they circulate in blood, not as a free T3, T4 molecule. Okay, they are bound to thyroid binding globulin, TBG. Okay, so as TBG increases, thyroid binding globulin increases, total T3 and T4 increases, but free T3 and T4 remains normal. So if you perform thyroid function test in a pregnant mother, always perform free T4, not total T4. Okay, if you perform total T4, যদি মাদারের total T4 টেস্ট করো তাহলে ভুল হবে, T4 বেড়ে দেখাবে, বাট মাদারের হাইপারথাইরয়েডিজম নেই, রাইট? Hyperthyroidism নেই, but it will be falsely coming as high T4. So what you need to do in the pregnant mother, you need to do free T4 assay. যখন আমরা পেশেন্টের থাইরয়েড ফাংশন করতে দিই, তখন আমরা ফ্রি T4 করতে দেব, কখনোই টোটাল T4 নয়, তাহলে কনফিউজড হয়ে যাবো, রাইট? Okay, insulin resistance increases in the second and third trimester due to placental hormone, human placental lactogen, right? HPL. Insulin resistance increases in second and third trimester. Okay, and when this is uncontrolled, it may cause gestational diabetes. Okay, when this is uncontrolled, and particularly if the patient is, or the mother is previously diabetic. Okay, when the mother is previously আগে থেকেই mother diabetic অথবা mother-এর impaired glucose tolerance রয়েছে, then the chances of developing frank diabetes is very high. Okay, because pregnancy is already a state of insulin resistance. Okay, যেখানে mother-এর আগে থেকেই insulin resistance রয়েছে before conceiving, right? তাহলে mother-এর আগে থেকেই যদি insulin resistance রয়েছে, and the pregnancy on the top of that is again a state of high insulin resistance. Okay, তাহলে diabetes develop করবেই, এবং you need to treat the patient with insulin, right? Okay, because most of the oral hypoglycemic drugs are contraindicated in pregnancy. That is why you need to treat the patient with insulin only. Okay, so risk of gestational diabetes. Once the mother is having gestational diabetes, what will happen to fetus? Many times I have told you what will be the effect to the fetus if the mother is diabetic and the mother is diabetic having gestational diabetes and the mother is not treated with insulin? What happens to the fetus? বাচ্চার কি চেঞ্জ কি হবে? What happens to the fetus? What happens to the fetus when the mother is diabetic and not treated with insulin? Mother glycemic control is not okay. What will happen to the fetus? বাচ্চার কি ক্ষতি হবে? ক্ষতি তো হবে। Any idea? What is insulin for the fetus? Insulin কি করবে? আচ্ছা, এটুকু তো বলা যাচ্ছে যে mother and fetus is separated by what? Placenta. Mother and fetus is separated by placenta. So if the mother is not treated as gestational diabetes patient is not treated with insulin, so maternal hyperglycemia, simply glucose, so it will cross the placental barrier, right? Glucose ke to atkate parbe na placental barrier e protein atkate parbe, boro boro protein atkate parbe, right? So placenta cannot stop glucose from sugar from entering into fetal blood. So maternal hyperglycemia will cause fetal hyperglycemia, right? Maternal hyperglycemia will cause fetal hyperglycemia. Now what will be the response in the fetal's pancreas? High insulin, okay? So fetal pancreas will try to defend this hyperglycemia by increasing insulin secretion, right? So fetal blood, initially in the fetal blood there will be hyperglycemia, and later on in fetal blood there will be hyperinsulinemia. Okay, hyperinsulinemia in fetal blood will cause what? Insulin is, I have told many times during general physiology classes that insulin is a growth factor for fetus. Okay, it is not growth hormone. Okay, only growth hormone causes growth only after 1 year of age. Before that, the major growth hormone is insulin and insulin like growth factor 1, IGF-1. Okay, up to 1 year of age, again very important MCQ zone. Okay, very important conceptual part, very important MCQ zone. Up to 1 year of age, okay, fetuser growth ke kore? Growth hormone noy, right? ফিটাসের গ্রোথ হরমোন করে না, ফিটাসের গ্রোথ কে করে? তিনটে জিনিস, নাম্বার 1 ইনসুলিন, নাম্বার 2 ইনসুলিন লাইক গ্রোথ ফ্যাক্টর 1, নাম্বার 3 থাইরক্সিন। ঠিক আছে, there are only 3 hormones responsible for fetal growth. One is insulin, second is insulin like growth factor 1, third is thyroxine. জীবনে কোনোদিন ভুলবে না, right? Fetal growth, not only fetal growth, after birth up to 1 year of age, after birth up to 1 year of age, growth is caused by insulin like growth factor 1 or IGF-1 and thyroxine, right? Never forget. Okay, so now due to fetal hyperglycemia there is fetal hyperinsulinemia. This fetal hyperinsulinemia will cause fetal growth, excessive fetal growth. Causing excessive fetal growth, we call it macrosomia. So the baby will be 3.5 kg, 4 kg and even more than 4 kg, right? So it will be difficult to do a normal delivery, and we need to move for a cesarean section, right? And also there are some other abnormalities as well that you will study later on. So the basic problem is fetal macrosomia. Fetus's size খুব বেড়ে যাবে, body weight খুব বেড়ে যাবে। Normal birth weight কত? 2.5 kg একটু বেশি, right? 2.5 kg, more than 2.5 kg is normal birth weight, but in a fetal macrosomia it will be 3.5 kg, 4 kg, 4.5 kg, right? Okay, and it is very difficult to do a normal delivery, and ultimately the patient need to undergo a cesarean section. Okay, so next, risk of gestational diabetes, and next is increased cortisol. Why there is increased cortisol? Because pregnancy is a state of stress. Okay, pregnancy is a state of stress where there is increased hypothalamo-pituitary adrenal axis. Okay, increased activation of hypothalamo-pituitary adrenal axis. Okay, and also there is increased production of placental CRH. From placenta, one hormone is secreted, CRH, placental CRH, corticotrophin releasing hormone, right? And this corticotrophin releasing hormone, it stimulates maternal hypothalamus. Okay, placental CRH, it stimulates maternal hypothalamus and causes increased secretion of ACTH. Okay, increased secretion of ACTH, and ACTH, increased secretion of ACTH means increased cortisol. Okay, clear? So cortisol is a high. Cortisol is high, and it is a state of stress. So that is why nowadays therapy is coming to combat stress during pregnancy. Okay, how to alleviate stress in a pregnant mother, right? Musculoskeletal system, these are easy only. Lordosis due to increased abdominal weight and ligament laxity due to the hormone relaxin, increased joint mobility and pelvic expansion that is required. I told you that everything has got a purpose. Okay, everything has got a purpose. You have studied pelvis in anatomy. There are lots of ligaments, right? There are lots of ligament over here, right, in pelvis. Okay, so there is laxity of those ligaments because it is to prepare the mother for the delivery. Okay, it is to prepare the mother for the delivery, and it is due to the hormone relaxing. Skin changes. Okay, most important skin changes is hyperpigmentation. Okay, mother undergoes hyperpigmentation. Okay, hyperpigmentation onek jagay hoy. Okay, so see, first of all, what is the reason of hyperpigmentation? Hyperpigmentation keno hoy? Okay, skin hyperpigmentation keno hoy? So one is hyperpigmentation, and another is the spider angiomas, palmar erythema due to increased estrogen. Okay, if you see patients of chronic liver disease with high estrogen, then also you will see this spider angiomas, palmar erythema. So these are features of hyperestrogenemia. Hyperestrogenemia. Any patient developing hyperestrogenemia, like a patient of chronic liver disease, they will develop these things: spider angiomas, palmar erythema. So these are commonly seen in a pregnant mother due to the state of hyperestrogenemia, and also hyperpigmentation of the areola, linea nigra, face, melasma, cloasma, right, and stria gravidarum or the stretch marks. These are all due to hyperpigmentations. And what is the reason of hyperpigmentation? Hyperpigmentation is again due to placental CRH. This placental CRH, it stimulates maternal hypothalamus, okay, causing increased secretion of ACTH. And you know, during ACTH synthesis, one byproduct is MSH, that is melanocyte stimulating hormone. Okay, so there is two reasons basically. One is estrogen stimulates melanocytes, and another is placental CRH. It is activating maternal hypothalamus, causing increased ACTH, and ACTH का byproduct है MSH, melanocyte stimulating hormone, right? So increased MSH is a byproduct of ACTH. Reproductive system. Finally, what happens to the reproductive system? The most common and the visible thing, reproductive system, right? So uterus enlarges, its weight changes from pre-pregnancy state of 70 gram to 1000 gram in a term pregnancy, right? Cervix softens, okay, cervix softens, it is called Goodell sign, and becomes vascular, it is called Chadwick signs, and there is increased blood flow in the vagina, there may be leukocyuria as well, and breast enlarges, nipple darken, Montgomery glands prominent, and there may be synthesis of colostrum. What is colostrum? First milk, right? So colostrum synthesis or colostrum production may initiate. Okay, so these are all effect of estrogen, right? So these are the signs, very Goodell sign, Chadwick signs. These are important. These are very important for MCQ, and in gynecology and obstetrics, you need to check these things. Okay, you need to check these things for pregnant mother. Okay, and these are also common question in gyne-obs. Okay, nobody will ask you in physiology what is Goodell sign, what is Chadwick signs. Okay, there are many other signs as well. So we will know how to examine a pregnant patient and how to check those signs in your final year gyne-obs, right? But right now you need to prepare a long question for changes in the physiological changes in the pregnancy. That is important, and if you explain why things focused on ESR increase, okay, few things like hyperpigmentation in pregnancy. So these are explain why zones, right?